or afternoon, depending on where you're joining us from, and welcome to Myeloma Australia's third and final online seminar for National Myeloma Month. My name is Alicia. Myself and Tina will be chairing today's seminar. To begin today's seminar, we'd like to acknowledge the traditional custodians of the country throughout Australia and recognise their continuing connection to lands, water and culture. We pay our respects to their elders past, present and emerging. So our theme this year for Myeloma Month has been wellness and possibility. Today's seminar will run for approximately 2 hours. In the first half, we'll be hearing from Dr. Kerry Mellahan about sleep, and then nurse consultant Simone Sheridan on intimacy and relationships. There'll be a 5-minute break. Following the break, we will be hearing from Maria McDonald about caring for the carer. And then Narelle, one of our other wonderful support nurses in WA, will be interviewing Peter and Deirdre Brune about their experiences living with and caring for someone with myeloma. We will have time at the end of each presentation for questions, and we encourage you to ask. Please just use the live Q&A box at the bottom of your screen. To join the chat, you first just need to enter your name and then click join. If you don't wish to use your name, that's totally fine. Please just type anonymous instead. You can also like someone else's question if they've asked something that you'd also like an answer to. So any questions that we don't manage to get to in the live format, we will endeavour to answer via email over the coming week. If you do have any technical difficulties, there is an email or a phone number on the left bottom side of the screen and you can use, and our team will be available to assist you. Please note this seminar will also be recorded and saved to our website for you to view at a later time if you wish. Generally, the video will be available on the website 7 days after recording. Now, I'd like to introduce our first speaker, Dr. Kerry Mellahan. Kerry is a sleep scientist currently working in the sleep unit at the Royal Prince Alfred Hospital and also teaching sleep medicine at the University of Sydney. She's been a sleep scientist for more than 20 years, working in sleep clinics, and has been involved in lots of different research studies in sleep. Welcome, Kerry.
Fabulous. Thank you, Alicia. So what I'm going to be talking about today is obviously sleep. Now, I'm not an expert in myeloma, but I do know a fair bit about sleep. And from what I understand, there is a lot of issues regarding the influence of medications onto sleep when there's myeloma involved. So I'm going to have 3 different sections in this talk. So the first one is about the function of sleep and a bit of the sleep basics. Then I'm going to cover good sleep habits, which everybody should follow. And then I'm going to give you some ideas of what to do if sleep is a bit of an issue for you. Okay, so, and all of those things, all of those recommendations, some might work, some might not. So we just need to work out which one is going to be the right for you. Okay, so we'll start off with sleep. And the first thing I'd like to explain is about what happens when we go off to sleep. Sleep isn't just an on-off switch. There's actually a lot of things that happen during sleep. And there's different sleep stages that we go through during the night. So this is a representation of the different sleep stages across the 8-hour period. So stage N1, called non-REM sleep. Stage 1 is like, you know, when you're just sort of dozing off and you're just falling asleep in front of the telly or just dozing off. That really light sleep is called stage N1 sleep. Stage 2 sleep is sort of your garden variety sleep, the sleep you have when you're not having the other sorts of sleep. Stage 3 is the deep sleep. That's where if somebody wakes you up, you're a bit dopey and you might not wake up quite so quickly and that sort of thing. And stage REM sleep is where the majority of your dreams happen. So your brain is actually really quite active. There's a lot of thought processes happening, and your breathing goes a little bit different during REM sleep. than it does in the other stages, just fast and slow and whatnot. So REM is actually quite an active time compared to the other stages of sleep. So we rotate between those stages across the night, where a lot of the deep sleep, the stage 3 sleep, happens towards the beginning of the night, and more of the REM sleep happens towards the other end of the night when you're waking up from sleep. So the question of why do we sleep is actually a really big question, and there's actually loads of reasons why we sleep, and we are always finding out new things that happen during sleep, different functions and whatnot. So as one of the famous researchers said, if sleep wasn't important to our development, our growth, and our maintenance of health, why do we devote so much time to it? Obviously, it is an important thing to maintain health and our function. So I'll go through a couple of those. I've got 7 different reasons why we sleep. The first thing is that we organize information during sleep. So during the day, you receive a load of information. You have experiences, you receive information about all sorts of stuff. So during the night, the brain processes that, and it puts the information into various little sections into your brain to make sure that it's all organized, ready to retrieve next time. Reason number 2 is in following on from this, it embeds memories. So if we experience something tonight we're going to be embedding that memory. How these memories work is it depends on what sleep stage and what type of memory it is. Okay, so if we have something that's fun today, we experience something fun, someone made you laugh, or indeed you had some sort of unhappy experience today, those things are going to be embedded through the REM sleep. So we process those in REM sleep to be able to retrieve them later. We also, if we see something nice or whatever we see, that gets processed during REM sleep as well. If we learned something today, like you learned how to play the piano or to fix something on your car, or you learned a particular procedure, that gets processed during the non-REM stages of sleep. So you can see that we do need both of those types of sleep to be able to embed the memories properly. If you've ever seen the movie called Inside Out, this actually portrays this concept really, really well. And if you have not seen this movie, I highly recommend it. You can do that for homework. Go and watch the movie called Inside Out. It explains the process of embedding memories in sleep really, really well. I was so impressed and so excited when I watched this movie as a sleep scientist. Number 3 reason why we sleep, it regulates hormone release. So there's a whole bunch of hormones that get released during sleep. So the first one's like growth hormone. Okay, so growth hormone gets released during the deepest stages of sleep in the beginning of the night. And if you think of a teenager going through puberty, they're having a lot of growth hormone. So teenagers actually need a load of sleep, a load of this particular stage of sleep, so that the growth hormone can be released and processed properly. So you'll find that teenagers do have a really long sleep period, and they are biologically programmed to sleep a little bit later. So when your teenager wants to sleep in during the morning, then probably it's due to normal sleep physiology, and we want to be able to let them do that because the growth hormone is being released. Testosterone is also released during sleep as well. So if there's interrupted sleep, testosterone may be affected. We've also got cortisol, which is released during the day and which drops off at night, but it is released just as we're waking up in the morning. Our melatonin is released before we go to sleep, and then that helps us go off to sleep. Reason number 4 is one of the newer things that we're finding out about sleep is that it removes brain waste. So everything that we do in our body, we use glucose to be able to provide us energy. We use all sorts of energy products for things to work in our bodies. The same is for our brain. Okay, so the brain takes in glucose, it uses that glucose to be able to make the brain function, to do all of the things it needs to do. And part of what happens with that is it produces waste. It uses up what it likes, and then there's these waste products afterwards. So what happens at night is that it gets cleaned up. So there's these little buildup of waste products called beta amyloid proteins. They're those little white things that's wrapped around this neuron. So what happens is during sleep, the brain just shrinks by a tiny little bit, and all this fluid comes in and it washes all of these little beta amyloids away. So it's like coming through with a hose, and it washes all of that waste product away. So in the morning, you wake up fresh, it's gotten rid of all of those waste products. Sleep also maintains sexual function. So during REM sleep, one of the normal physiologies is that men have erections. Women also do, but it's harder to document and notice. But men have erections during REM sleep. Thus my mention about morning glory in the morning. This is when REM happens, might wake up with an erection. So one of the theories with this is a kind of use it or lose it kind of thing. We make sure that the erection is going to work during the day. Reason number 6, that it also allows for uninhibited information processing. So what happens during sleep is there's the frontal lobe at the front of your brain just goes offline. That goes offline and it's not quite working as well as it does during the day. Now, what the frontal lobe does is it holds all of your inhibitions and your logic. Okay, it makes you behave as you should in society. That's where all of the rules and the procedures and the you knowing what you're supposed to do to be a good citizen and behaving yourself. What happens at night is that brain goes to sleep. And so your brain now has some freedoms to think about things in a non-inhibited way. And this can be a good thing and a not so good thing. So some of the good things are, if you go to sleep with a problem, your brain can then at night process that problem and come up with some interesting solutions that you wouldn't have thought of during the day, because all of those other embedded societal enforced rules place on you. So many a time, and many a researcher has there been an occasion where people say, sleep on it, or I woke up with an idea, or I thought about it during sleep. And that's the reason why this frontal lobe goes off to sleep, and you can come up with new ideas. So there's a lot of artists come up with great ideas for new artworks, and all sorts of stuff happen during this stage, during sleep. One of the bad things is that if you have a problem and you are ruminating with it overnight, it can feel a lot worse during the night than it does during the day. And that's because your logic has gone off to sleep and is no longer involved. And the things that say, no, actually, it's not that bad. But during the night, it can feel really bad because of this frontal lobe going off to sleep. So this allows some of those memories and information processing to happen. It thinks about this in a non-inhibited way to be able to process that information. And reason number 7, which should be number 7, is sleep maintains our immune system. So, when you're sick, you feel like you need to sleep. And one of the basic nursing principles is when you're sick, have some sleep. And there is a lot of science behind this. During sleep, there is a lot of cytokines being produced and released during sleep, and they help with the immune function. And there's some antibodies that are released during sleep as well that will go out and sort out some injuries and rejuvenate some of the cells that might be broken or anything like that. And there is some research to say that, like, if you had the flu shot, having a good night's sleep that night after you had a flu shot means that the efficacy of that vaccination is improved compared to not sleeping that night before. We don't know anything about how this has affected the COVID vaccination because we weren't in a position to research that, but we know that from a pre-COVID flu shot, there is an improvement in the efficacy of that vaccine if you sleep better that night, if you have a full night's sleep. Okay, so there's our summary, really quick guide to why we sleep. We organize information, we embed memories, we regulate the hormones, we remove the brain waste, we maintain the sexual function, and we maintain immune function as well. Now, what is normal sleep? Okay, now, normal sleep, we know what normal sleep is, right? So if you think about what normal sleep is, but culture actually has a huge impact on what you believe normal sleep is. So it's only in the last couple of 100 years where we've started to share a bed. We are, we used to sleep in a big open environment. Everybody slept in the same room kind of thing. We might sleep here and sleep there during the day. The 8-hour sleep is actually a reasonably new idea as we look at it in history. Our age obviously affects what's normal sleep as well. So for a baby, what's normal is different than a middle-aged person, different than an elderly person. So recognizing that these things influence your sleep can be really important for knowing what's kind of normal and what's not as normal as others. So what I wanted to talk about here is modern sleep versus pre-industrial sleep. So imagine the world pre-industrial revolution, okay? So we didn't necessarily have these 8-hour periods of work or 12-hour periods of work, whatever we do. What we expect now is that we sleep at nighttime and we are awake during the day. This is not necessarily how we've always slept. There's some examples and information in the older literature, in prayer books and old literature and art and all sorts of things that refer to first sleep and second sleep. So segmented sleep is something that happened that we've got documentation for in the Middle Ages in Europe, for example. So some places will have a first sleep at night and then have a second sleep in the afternoon, like a siesta. Other places, we have 2 periods of sleep with a waking period in the middle. So there's prayer books that say, this is a prayer for the wake periods between the first sleep and the second sleep. There's artworks that refer to this. And waking up in the middle of the night was considered an incredibly normal thing to do. So you might get up and tend to the animals, you might just say good day to your neighbor, you might go and do something in the house, some housework, that sort of thing. It was incredibly normal in this particular period of time to have 2 cycles of sleep. And there might be some more sleep during the day as well. So what I'm trying to get across here is that we have this modern construct that we sleep in 8 hours, we are awake for the rest of the day. It's not always been like that. The daytime siestas are pretty common in a lot of cultures, and they're part of normal sleep as well. Not necessarily normal everywhere, but they are in some cultures. Now, I showed you the hypnogram before of a middle-aged adult and their different sleep stages. So there's actually expected changes in this as we age. As we age, there's more awake periods during the night. So where there's no color in here is where we are awake. And so the periods awake as we get older increase. So we never sleep as good as we did when we were 20. As we age, our sleep is also going to be not as good as it was when we were younger. So normal sleep, according to culture, it does have a lot of influence from that culture. The sharing a bed, whether it's sharing a bed with your partner or with your pet, or indeed with your children, there's a lot of influences going on there. Okay, and around about 25% of Australians do share with their pet, according to a research study. So why do we need to know about this? So the cultural influence is actually, it changes what our expectation of normal sleep is. And if we can sort of change what the expectation is, then it you may not experience poor sleep as badly. Waking up in the middle of the night for an hour or more has been considered completely normal in times past. When we do a sleep study in a sleep lab, we expect about 86% of the night being asleep. We would expect you to be awake around about 14% of the night, and that's pretty normal, okay? So sleep, mood, and pain are all incredibly integrated. So when we go to sleep, we need to sort of turn down our receptors to influences such as noise and such like. But we also need to know if our house is on fire. So we need to have some level of receiving input. So we do still receive information about being uncomfortable, being in pain, that sort of thing. And this is highly involved in the sleep cycle, and they can influence each other. It's quite a complex interaction. So I'm just going to cover 9 good sleep habits that everybody should follow. Okay, so regular wake-up time. Regular wake-up time is way more important than a regular bedtime. The reason being is that the light will come into your brain, go through your eyes to the sensor at the back of your head that says now is the time to be awake. So if you do that every day, including days where you're not working and don't have any commitments, this is key. We should all be waking up at the same time. Create a comfortable sleeping environment. So invest in whatever it is that makes you comfortable, okay? Highly recommended. The only thing you should do in bed is to sleep and have sex if you like. That's okay. But that's the only things that happen in bed, nothing else. Respect sleep, but not too much. Don't obsess about it. You've got to respect your own sleep. Sleep is part of the 3 good things we need to do with to maintain health: exercise, nutrition, and sleep. Okay, you need to allocate appropriate time for sleep, but don't put too much pressure on it. It's you're counterproductive if you are trying to sleep too much. You also need to respect other people's sleep as much as they respect yours, and teach other people to respect your sleep, because you'll be affected by your family, by the neighbors, all sorts of things that affect your sleep. And your sleep's important. So make sure that you respect yours, other people respect it, and you respect theirs. And we need to talk to our children about that they need to learn to sleep to help them learn and play. So if we embed that in our children when they are young to maintain good sleep habits, then that's going to be really useful for them later in life. Schedule wind down time. So we need a bit of time for our heart rate to reduce, our cortisol to reduce, all of those sorts of things. Whatever it is for you, whether it's watching old episodes of Big Bang Theory on Netflix or whatever it is, just have some time before you go to bed just to chill out for a bit. Don't do running around and then try to go to sleep. It's not going to work. Okay. If you want to listen to some music or do whatever, that's fine. But schedule some wind down time before going off to sleep. Avoid caffeine in the second half of the day. So caffeine's half-life is about 5 to 6 hours. So if you have a coffee at 3 o'clock in the afternoon, about half of that's still going to be active when you try and go to bed at like 9 o'clock, if you were to go into bed at 9 o'clock. So avoid caffeine in the second half of the day. There is some individual differences in this. Some people do not find that caffeine affects them, and that's okay. They can have a coffee and not affect them. That's fine. But if you're somebody who is affected by caffeine and that it wakes you up, then avoid it in the second part of the day. Have an open discussion with your bed partner about rules regarding to sleep. It's like a little battleground in sleep. Each person, if you're sharing a bed with somebody, each person has their own beliefs about things, whether you should have the windows open or closed, whether the curtains open or closed, whether you allow the pets in the bed or not, the times that you get up and get out of bed, is the bed big enough for you, all of you? So this is one of the things that if open discussions about what likes and dislikes you have to try and maintain both of your sleep. And remember that sharing a bed is actually a relatively new phenomena in human history. We didn't used to do this. It's only been the last 200 years, or give or take, that we have been sharing bedding. So our blankets used to be our own, and we would share in a communal environment. And it's once we've started to share a bed and resource sharing, that's where these issues have started to come up. Don't watch the clock. Don't have any clocks in your room. If it's dark, you should be sleeping. That's it. The only clock that you might have is have an alarm on it if you need an alarm to get up at a certain time, but do not watch the clock overnight. And number 9 is limit alcohol intake. So what alcohol will do is it will reduce the time that it takes to go to sleep, but it will interrupt the second half of your night. So it will cause you to wake up a lot more during the night. Okay, so moving on to some suggestions to those who have difficulty sleeping. And as I said, everybody's different. Some will work for some and not for others. So the aim is to reduce your anxiety about bedtime and reduce the amount of wake time in sleep. So for some people, going to bed, it can be a cue for distress and frustration in falling asleep. We want to get rid of that anxiety because that's counterproductive. So we aim to get rid of that so we can improve sleep. Okay, so Zeitgebers are cues to go off to sleep. So if you can utilize these cues to go off to sleep, then that's a fantastic option. So with showers, if you warm yourself up, falling off to sleep involves a slight fall in body temperature. So if you have a nice warm shower beforehand and try and catch that downward drift as the temperature comes down again, then catch that. If you have just a regular, a once a day, no caffeine drink before you go to bed, you can use that as a Zeitgeber. Say, now is the time to go to sleep. You'll be amazed at how much the body listens to that. If you want to listen to a podcast, that's okay. There's some podcasts out there that have really nothing going on. The purpose of this podcast here is nothing much happens. All it is somebody reading out a story that doesn't actually go anywhere, so that you can lie down and listen to podcast and listen to it, and it gets so boring that you end up falling off to sleep. My favorite podcast, and I listen to Downton Abbey every night. I go off to sleep to listening to Downton Abbey every night of the week. So I know the story, I know every scene. I listen to it and I picture the characters and I fall off to sleep. And it doesn't matter if I don't hear the end, because I know the ending, I know what happens. Okay, so that's my special trait. And going off, having a busy brain is often one of the big things that people complain about. And we need to be able to control this busyness. So anything that works for you. So if it is meditation, yoga, reading a particular book, or prayers, or anything that does it for you, and it doesn't have to be anything particular, to just calm that brain, you'll need to figure out what that is for you. Okay. White noise can be useful as well. There are apps available which just create a bit of a background noise, or in real life as well. So that can help some people as well. As I said, utilize the shower to go to bed, utilize body temperature changes to help you go off to sleep. Make sure that if you do use your phone near sleep, reduce the brightness and use the blue light filter. What the phone does is it's shining light straight into your eyes, straight down that track that's sending the information to the back of your brain to tell you that it's awake time. So reduce that and take out the blue light of that as well. There's a 15-minute rule that says if you are awake for longer than 15 minutes, get out of bed and go and do something else. So whether that's folding the washing or just reading a book or something non-stimulating that's not going to get you too involved, and then go back off to bed. Okay, so if you're awake more than 15 minutes, get out of bed, go and do something else until you're tired. And eventually you feel sleepy and go off to bed. If you need to do this multiple times, eventually you'll end up reducing the amount of time in bed being awake, and that's our goal. We need to reduce the amount of entertainment at bedtime, whether that's coming from books or internet or movies. We need to be able to not have that sort of entertainment involved. And we need to be able to control our behavior, whether we're thinking too much, whether we're worrying about processes, which is going to affect our sleep, whether we're checking emails late at night or eating in bed or eating late is going to be affecting things. So we need to control those behaviors as well, which is going to be helping sleep. There are online courses available which you can sign up for and receive help from a insomnia perspective. So all of these ones that I've listed here are well researched, decent, run by good people, organisations. You do need to pay for some of these. So if you are in a position that needing a bit of help, then feel free to use some of those resources there. And that is a very quick run through of sleep and a few hints to help you with your normal sleep and if you're having any difficulties. So thank you.
I have to say, I've been sitting here and just feel in the last half hour I've learned so much about sleep, and I'm a bit embarrassed as a nurse that there was so much, particularly around the physiology, that I wasn't aware of, particularly around the frontal lobe being switched off and how that really affects
Mhm.
Our
There's a
brain.
huge amount of physiology involved, and I wish that I could teach more nurses all about this and help our patients in hospital get decent sleep, because it's going to help their recovery and reduce time in hospital and all that sort of stuff. So,
Oh,
yes.
look, yeah, you don't go to hospital for a good night's sleep. That's
No.
for sure. Now, we do have a question from one of our viewers. So, Kate has asked, I have nocturia and have to go to the toilet every hour throughout the night. Is this harmful to my brain?
No, not in a direct way. So, as I said, part of normal sleep in the Middle Ages is that we did wake up in the middle of the night and do stuff. If you are getting enough sleep over a 24-hour period, then that's okay. You know, that's achieving most of the functions that it needs to achieve. If you have like a sleep disorder such as sleep apnea, which is interrupting your sleep every 15 seconds or so, then that can have some effects, and we need to sort that out to prevent any further. But if you're sleeping nicely and then your bladder goes, oh, hang on a bit, I need to sort that out, wakes you up, you go off to sleep, and then you go back up, and then you get up, go to the toilet, come back, go back off to sleep, that's okay, because your sleep is doing what it needs to do during that time. So as long as you get that over a 24-hour period, yeah, you're sweet.
I hope that answered your question, Kate. I guess it ties back quite nicely into what we culturally think of at the moment, you know, in today's society of what is good quality sleep versus actually, you know, what our brain needs.
Yes, absolutely. And yes, go ahead.
Yeah, no, that's fine. Yeah. No, thank you very much for that, Kerry. Again, absolutely fascinating topic. And I'm sure everyone watching and those watching on playback have got a lot from it. So thanks so much for taking time out of your busy schedule to join us.
No problem. Thank you.
Okay, so now we'll move on to our next presentation. I'd like to welcome Simone Sheridan to the seminar. Thank you so much for joining us, Simone. And Simone works as a sexual health nurse consultant at the Austin Hospital in Melbourne, where she sees clients experiencing a range of sexual difficulties as a result of illness or injury. She also works privately as a nurse consultant with the organisation Thrive Rehabilitation. She's passionate about supporting health professionals to have conversations about sex and intimacy and regularly facilitates education on this topic. Prior to specialising in sexual health, Simone worked as an ICU nurse and clinical nurse educator at Peter MacCallum Cancer Centre. Recently, Simone appeared on the ABC program Conversations, and stories from her work were documented in the book, The Care Factor. Thank you so much, Simone.
Thank you so much for having me. It's so great to be here today, being able to talk to you about a topic that's very close to my heart, which is those awkward conversations, talking about sex and intimacy. Gosh, they can be awkward at times, can't they? Whether that's talking with our health professionals or talking with our partners, things can feel a bit tricky. And I guess I just want to say from the outset, I love talking about sex. Absolutely love it. And I think that's probably a really good thing, because that's what I do a lot of the time in my work. So like Alicia was saying, I talk with patients from a wide variety of background, not just cancer, but patients that have had a spinal cord injury or a stroke, or something else that's an injury or an illness that's impacted their sexual function. And I also talk with health professionals about building confidence into how we can have these conversations in a healthcare environment, because we really need to. So I'm hoping today in this short presentation, we can talk about how we can hopefully make these conversations a little less awkward. So from the outset, I want to just say, this is a very obvious thing, but sex is not just about making babies. Like, babies are great, babies are very cute. We wouldn't be here if babies weren't able to be made through sex. But I think this is one of the things that gets in the way of us having conversations about sex and intimacy, is that we tend to feel much more comfortable talking about fertility. You know, if there's an egg and a sperm and we're talking about fertility or fertility preservation or contraceptives, it's awkward, but it's not that awkward. Once we stray into the realm of pleasure and fun and arousal, things get really, really tricky as well. So for this talk, we're not going to be talking about fertility. We're going to look at the other aspects of sex and intimacy. So the World Health Organization takes a really broad view to the idea of sexual health. You know, it says that it's actually a physical, mental, and social well-being in relation to our sexuality. We all have a sexuality. It's a very unique thing to us. And it's really important that we don't just look at sex in a very narrow way, but we take a very broad view to sexual health. And the World Health Organization also says that it's everyone's right to have pleasurable and safe sexual experiences, safe being the key here, that are free of coercion, discrimination, and violence. And I want to say from the outset that we're going to be talking about sex for the next 20 minutes or so. And not everyone's sexual experiences are positive. So really important that we put out there one of the great supports that are available in Australia, which is 1-800-RESPECT. This is our national sexual assault and domestic violence family counselling service. So if anything we're talking about today brings up thoughts for you or feelings, or if this is something you'd like to talk to someone about some experiences you've had in the past or are currently experiencing, please reach out to 1-800-RESPECT. It's a fantastic service. Okay, so we're going to talk a little bit about intimacy. You know, I think sometimes when we're thinking about how am I going to have a conversation about sex, intimacy is a great word because it's a bit of an easy way to ease into things. I'm sure we're all pretty familiar with this concept of intimacy, that it can come in many different forms and that it's a closeness in a relationship. It's a sense of connection, of safety, of trust, and of love. And yes, there's sexual intimacy, which we will talk a lot more about. But intimacy can have a physical element that's not sexual. Intimacy can be emotional and intimacy can be spiritual. And I'm sure thinking about the relationships in your life, there's varying degrees of intimacy with people. And when we're thinking about sex as related to intimacy, we kind of need to dive a bit deeper into, okay, well, what is sex? If intimacy can be so broad and can happen between so many different people in different relationships, what is sex? Now, I'm sure if I got you to draw me a diagram or tell me what sex is, there's a pretty dominant narrative in our society that there's generally genitals involved, there's often a penis and there's a vagina, and things happen between those genitals. But I think what we need to do is actually step back and look at sex much more broadly. And, you know, I love this definition of sex, that it's a physical contact that brings excitement and pleasure and connection. Because in actual fact, our two biggest sex organs are not our genitals, it's our brain and our skin. And we can experience sexual pleasure and sexual intimacy in such different ways. But sometimes we get really caught up on what's not working and the specifics of what we think makes traditional sex. And, you know, even that idea of physical contact, I was thinking about like over the pandemic and times during lockdown when people weren't able to actually come together physically, there was actually a lot of sex that went on. You know, during that time was the highest sales of sex toys. And there was a lot of people connecting in physical ways that maybe they were touching themselves whilst being in contact with someone else digitally as well. But if we're talking about what sex is and all the broad things that sex can be, we also need to talk about what sex is not. And sex is not limited to intercourse. I think this is a really important thing, that if we're going to have sexually satisfying lives, we need to really step away from that idea. And also really important that sex is never a should and never a have to. This is something that people want to engage in because it's something that's pleasurable for them. And if it's a should or a have to, that's not sex, that's actually rape or sexual assault. Okay, but thinking about what are the benefits of safe, pleasurable, consensual sexual activity between two adults who are like, this is what we want to do. And whatever variety of sexual activity that happens, what are the benefits? Why do we get so excited about it? And why am I actually here talking to you today? Well, there are so many things in the literature that tell us how good sex is. How good is sex? It improves our sleep. Thinking about the sleep talk that we just had before, sex is also a great strategy to help with sleep. It counts as exercise. It can have those physiological benefits on our blood pressure. It can really establish a sense of intimacy and connection through the hormones that are released as a result of sexual pleasure. And again, those endorphins that are released can give us some level of pain relief as well. It can give us a sense of well-being in ourselves and in our relationships. It reduces stress, and it's pretty bloody fun. There are so many reasons why being sexually active with someone that we love and that we're in a relationship with that feels good to us can bring really good benefits into our lives. And there was a doctor that I used to work with that I loved, that she had this quote. She said, if sex was a pill, we'd prescribe it to everyone. So this is it. It's really important. And we are all sexual beings from the time that we're born until the time that we die. We never stop being a sexual being. The ways in which we express our sexuality, the types of experiences that we like to have, the types of activities that we want to be involved in, that's going to change over our lifetime. And so there's going to be a huge amount of diversity in how we express ourselves as a sexual being, but that's always going to be there. This is part of what it is to be human. And we know from the research as well that sex is it's a part of quality of life. It's a really important thing to people. And again, it comes in many different forms and different ways, but it is something that concerns all of us. And I think sometimes I'm sure you've probably heard many times this idea of the cancer journey or the myeloma journey. And, sometimes that can feel a bit irritating, that kind of terminology. But I think sometimes it's a bit useful to think about, especially if we're thinking about sex and intimacy, that we all come as individuals to the point at which there's an illness or an injury, such as myeloma, that happens. And there might be a whole lot of baggage that we're already carrying. There's a whole lot of things that might have happened, thinking particularly about sex and intimacy. There might be ways that we already relate to our body or don't relate to our body. There might already be levels of sexual dysfunction going on. And then we add on an illness such as myeloma, and we add on treatments, and we add on medications, and that can really disrupt that connection with our sexual selves. And what we do know from around the world, that this problem is actually really understudied. We don't know a huge amount of the detail specifically about people with myeloma, but we do know some kind of broad information about people with hematological malignancies. And we know that they experience sexual problems at a greater rate. And this makes a lot of sense when we think about why it might be. And we know also that people who've had a stem cell transplant, looking 5 years into the future, a lot of these people are reporting that they do have sexual dysfunction. And I want to say from the outset that a sexual dysfunction is defined as a sexual problem that's causing a problem, that's causing distress to somebody or distress in the relationship. There are lots of changes that happen to a body over its lifespan that don't cause distress. Things might change and someone might go, that's changed, that's okay. In that case, that doesn't get classed as a sexual dysfunction. It's classed as a sexual dysfunction when it's actually causing distress to someone. But we can see that there's actually a need to talk about this in healthcare. And these types of problems might arise in many different areas. So it might be a case that there's a loss of libido or desire, this feeling of wanting to be intimate with someone. That can really change over the course of someone's cancer treatment. There can be changes to arousal, and that might appear as if you have a vulva, a reduction in vaginal lubrication. There might be erectile dysfunction for people with penises, and there might be some changes to how ejaculation happens. And these types of dysfunction, particularly that reduction in lubrication, might lead to a feeling of dyspareunia, a painful intercourse. We know as well that there's lots of things in myeloma treatment that can actually damage the sensitivity of nerves. And those nerves also exist in our erogenous tissue. So we might get this decreased sensitivity of that tissue. And that might then lead on to a reduced ability to achieve orgasm. And as well, infertility, although we're not talking about fertility a great deal today, is a really significant sexual problem for people as well. So what causes these difficulties in the case of myeloma? There can be lots of physical illnesses that actually contribute directly. So there might be the myeloma itself, but there might also be other illnesses that someone else has going on in the background, whether that's high blood pressure, diabetes, other respiratory illnesses, other neurological illnesses that can cause sexual dysfunction directly. But then there can be kind of this secondary level of the treatments and the medications that are so important for treating these illnesses. A lot of them have really quite profound sexual side effects, whether that's our pain medications, whether it's the steroids that can lead on to having more diabetes and damage to nerves that way. We can actually see that many medications and treatments, whether it's chemotherapy, radiotherapy, different types of surgical treatments, can also cause dysfunction in their own right. And then there's those secondary effects of pain. Pain is a very huge turn off, isn't it? Like it's something that makes your body not want to go into a place where there's intimacy and enjoyment in physical sexual activity. And fatigue is a big one for people that are suffering from anemia, that effort that it might take to get into a place where sexual activity feels fun. And fear, I think, is really important to talk about. If someone's scared about an infection or a risk of bleeding, or if there's a partner who's really feeling really cautious or scared about hurting their partner who might be going through cancer and has myeloma, fear is a really powerful anti-arousal agent. And then, of course, any associated depression and anxiety and the medications that go along with that, any physical impairments, the relationship changes that are huge, the body image changes, the role changes, for someone who's used to having a certain role within their relationship. And on top of all of that, there's those normal impacts of aging. As a body grows older, a lot of those neurological pathways slow down, and a body's ability to, engorge blood vessels slows down. And this doesn't mean that sexual satisfaction is not possible. It just means that there might be the need to go about things in a different way. So you can see that, for someone with myeloma, there's so many reasons why this sexual dysfunction might be happening. And it's going to be very individual to that person's treatment and their pre-existing conditions. But we don't talk about it. So why is this that we've got such a problem that's going on in the background, and we know that it's a problem for people that they want to talk about, but unfortunately healthcare professionals are in a place where they're finding that they seldomly discuss these issues. So this figure here, 68% of healthcare professionals saying, I don't really talk about this with patients, comes from a huge European survey of health professionals working in haematology specifically. Interestingly, though, when they asked those same health professionals, did they think it was important to talk about this? 95% of them said, yeah, we think this is really important to talk about. So why are we not having these conversations? I'm sure you get this, that there's really big embarrassment factor. And there's an embarrassment factor on the part of the health professional, and there's an embarrassment factor on the part of the patients. And both in the research, what we see is both patients and health professionals, they want the other person to ask. If the other person asks, really happy to talk about it, but I feel really uncomfortable bringing it up. And there can be worries in the background on both sides about causing offense. Like, what if I actually offend this person? Am I making an incorrect assumption that, that person's too old, too young, of a different background to me, a different religion? Maybe they don't want to talk about it. And, we all just don't feel very confident talking about sex. It's interesting. You look at billboards, you look at magazines, movies, sex sells. Sex is everywhere in our Western society. And yet we're not very confident about having these conversations and, about the language we might want to use as well. And I think both healthcare providers and patients feel that real pressure, that lack of time or lack of privacy, or maybe this is not important. There's a lot more other important things going on right now. But what we do know from the research is that patients, and I'm really sure that you can back me up here, patients and their partners do want information about the effects of illness and treatment on their sexuality and intimacy. And we see this right across, not just cancer, but right across a lot of illnesses and injuries. People are saying, I want this information, but I'm finding it really hard to ask. So this is something that I'm heavily invested in, is actually helping health professionals develop these skills. And there's been a real change in recent years in training programs around supporting health professionals to realize, actually, it's your job to bring it up as well. Don't just rely on someone asking a question. Make it really easy and provide an opportunity for someone to ask if they'd like to ask. And I think that I'm really hoping, and maybe you can say in the chat or at the end when we have questions, let me know, have you been asked a question? I'd love to hear if there's been maybe a form that you were filling in and there was a place where you could tick to say, yeah, I'd like to talk to someone about sexual function. Or maybe a health professional said something like this to you. They might have said, many people with myeloma have questions about sex and intimacy. Is there something you might like more information about? And that's a really lovely way of being asked, because you can say, yeah, I do, or no, actually I don't. So it's a really invitational way. And this is something where we're trying to make sure that health professionals have in their toolkit. But I think probably there are lots of health professionals still who fall into that basket of, I feel really embarrassed and I'd like the patient to ask me. And so I'd like to give you a couple of tips just in case you have a health professional who feels a bit embarrassed but is waiting for you to ask. Here's some ways that you might be able to bring up your questions. So the first thing is, please know that this is an important health issue. There is so much research of both healthcare professionals and patients saying, yes, this is important. And I know that you're in a situation with myeloma where you're dealing with life and death issues. You're dealing with really big things and you're talking to someone about, potentially curing or prolonging your life in all of these ways. This is also an important quality of life issue. And so taking time to talk about it is valid. Choose who you feel comfortable with. It might, it's really hard sometimes picking the person who's going to be able to help best. So start with the person that you feel most comfortable with. If that's your physiotherapist, if that's your doctor, if that's your nurse, whoever the person is that you go, I could start there, that's probably the best starting point. If you have a session with someone and you think, oh, I'd like to ask some questions, one of the most common things that happen that we hear from health professionals is that patients right at the end of the session, they're reaching for the door handle to leave the room and they're like, oh, by the way, I've got a question about sex. That's a really hard time because it's quite a thing that we'd like to spend a bit more time talking about. So at the start of the session, if you want to ask a question, flag it early. And that's a good time because you can walk in with the confidence and you can say, actually, I've got a question about sex that I'd like to talk about in today's session. And then it's up to the healthcare professional to make sure that gets covered. Write down your questions. You know, if you feel like, God, I don't know if I can actually say this out loud, write it down and say, hey, I've got some extra questions. Pass over your bit of paper. That's another great way to go about it. And look, if you don't get the best response, if you feel like that person doesn't respond in a way that's helpful or doesn't give you enough information, try again. You know, you'll get better at it each time. Please don't feel embarrassed. Sex is a part of life. And so how it's impacted by your diagnosis is just another regular topic for discussion with your health professional. And that's what we know. Health professionals are really happy to have these conversations. It's just that they might be feeling a bit like you in that initial kind of initiating the topic feels a bit tricky. And there might be different questions you want to ask. And, you know, I'm sure that you'd have your own list, but here's just some that I've heard from people that, you know, have come up for them. You know, they might have questions around how does myeloma or the side effects of my particular treatment affect my sexual activity or affect my sexual function? Like what's going to happen? Or I've noticed something's changed and what could be causing those changes? Because the more you understand about what's going on with your body, the more power you're going to have. You know, somebody might be giving you information about, okay, I want you to make sure that you wear a condom while you're on particular therapy. Make sure you understand how that applies to lots of different types of sexual activity. So you and your partner might enjoy engaging in oral sex. Instead of just going, oh, I wonder if that applies to oral sex, actually ask it. And like, okay, well, how about oral sex? How about anal sex? What do I need to do in these particular situations? Are there any specific precautions? Or you might be at a place where being intimate and being sexual has been something that's been completely off the cards, not something that you've wanted to engage in. And now you're involved in coming back, you know, in a survivorship perspective, or you've, you know, finished your treatment and maybe you're scared about resuming that intimacy. Or maybe you're still having treatment, but you're at a point now where you think, oh, how could I get back into this? That's a really good question for your health professional as well. So your health professional can then provide information and education. Like I said, the more you know about the types of medications, the treatments, and how they impact your sexual function, you're not going to be second guessing it and going, oh, maybe this is happening for other reasons. Maybe I'm less attracted to my partner. You can go, no, this is happening because of this particular treatment that I'm on. Look, there might be some extra investigations that need to be done. You know, we know, for example, with erectile dysfunction, it might be that it's happening as a result of chemotherapy, but it might also be there's something else going in the background. So there might be some extra things that can be looked into. Your health professional can talk about, well, what are the treatment options? Can we actually change any of the particular medications that you're on to pick, you know, for example, there are certain types of blood pressure medications that are much more likely to cause sexual dysfunction than others. And of course, you want to have those discussions to go, well, what's going to be a safe option? There might also be options for medications, you know, for people with penises experiencing erectile dysfunction, you know, the drugs like Viagra might be an option. Talking about that with your health professional is really important. And then they can also open up other options in terms of referrals. So I think there's a lot of support that can be provided, and it's definitely worth checking in to find out what can support you. But communication is not just with your healthcare professionals, and actually probably more importantly in sex and intimacy is that communication in relationships. You know, I think particularly when there's been a really life-changing event like a cancer diagnosis, that can bring people together and it can actually force people apart. And it can mean that they don't talk about what's going on with their bodies. Or maybe in your relationship or in people's relationship, there's been a level of, we've got a sexual script that works for us. I do this, you do this, I feel good, this feels good, that feels great, great, we reach the end. And maybe that's how it's worked for 20 years. And then suddenly there's a diagnosis and there's all this treatment and medications, and that sexual script doesn't work anymore. And this might be the time to actually open up some conversations. So here's some tips or some ways that you might want to talk about things with your partner or your partners. So maybe it's about having a conversation. What does sex or intimacy mean to us? How important is it? What does it look like? You know, what activities make us feel connected? At times when connecting sexually in the way that we used to is not going to work at the moment, what can we do to keep that pilot light burning? You know, what are the things that we really enjoy doing together? What are the things that feel pleasurable? I think sometimes when we really narrow our view and we say, well, I can't have this particular type of sex anymore, therefore, whatever, I'm throwing my hands up, I'm done. But what actually feels good? There's going to be times when maybe having someone give you a foot massage, play with your hair, stroke your back, have a naked cuddle without any pressure for it to go anywhere. What's going to feel nice? How can you follow that pleasure without having this idea of it has to get to a certain destination? And really importantly, what are you both worried about? I think this is really a crucial one, because you might feel like, I know that I've heard from people in relationships feeling like, oh, since I've started treatment and my body's changed, I don't think my partner's attracted to me anymore. But what's actually going on for that person is they're really worried about hurting you. And unless you have that conversation about what are you worried about? What are you scared about? We need to actually open that up so we can start to have that dialogue. And a big tip, can I please give you one big tip? Any of these conversations, have them outside of the bedroom. It's going to be much easier for you and your partner having these conversations when you feel connected at a time that's not in the bedroom. Go for a walk somewhere, sit by the river, have a chat after dinner with a cup of tea, but yeah, take it out of the bedroom. You'll be surprised at how helpful that can be. So look, this is just such a short session, but there are so many things that can be really helpful in terms of reconnecting intimately with your partner. One of the big things, talking, reading, learning together. Sex is between two people. It's the couple's problem. It's not one person's problem. It's not one person's failing or inability. This is something that you need to work on together. So I'm going to give you some resources, but maybe picking one of those and looking at it together. Be up for trying new things, whether that might be trying a medication. Instead of seeing that as a failure, like, oh, I need to use this particular medication now to get aroused, maybe going, oh, I wonder what this could be like. Might be trying a different device, some vibrations, some different toys, taking the effort out of sex and bringing back in a sense of fun and play and novelty. Like if you think back to when you were a teenager and when you were starting to explore sex for the first time, it was pretty exciting and pretty fun and pretty nerve-wracking. And unfortunately, when it gets to the point later in life that things aren't working, they used to work, they're not working anymore, it can get pretty hard and we get focused on what's not working. We start getting really down about it. Sex starts feeling like a really heavy thing that I need to do something about. And gosh, that's not working either. And what we want to do is throw all that out the window and work out what's going to be fun in terms of reconnecting. Maybe we need to ban sex for a while so that we can actually go, what are we going to do to have a sense of play and fun together? And we might need to plan this in terms of connecting together intimately, might need to plan what time of day is going to work. And I think sometimes we think about sex and intimacy should be spontaneous and it should just happen. And in reality, anyone who's had kids, lived a life, had a job, you know that that's not going to be the case. That actually for everyone, and particularly for people with an illness, we need to think about what time of day, when am I having my medications? How do I feel after those? What sort of positions are going to feel comfortable? What sort of activities do I feel up for at the moment? But that sense of planning together can give a real intentional nature to sex and intimacy that can be really satisfying. So I think if you take one thing away from today's talk, it's that we really need to keep an open mind about sexual pleasure. There's your comfort zone, what you're used to, how you think sex works for you, and there's probably a whole lot of magic that can happen just outside of that. So some great resources to finish off with. The Cancer Council, fantastic booklet. Get your hands on it, read it cover to cover, read it with your partner. This book is regularly reviewed by sexual health professionals as well, so it's got lots of really good tips in it. There's a new book that's been brought out by, she's an OT, her name is Tess, and Tess is she's an OT, but she's also had cancer herself. She's got some great tips on rediscovering intimacy after cancer. I love this book, Come As You Are, by Emily Nagoski, who's a sex therapist in the States. It's particularly for people with vulvas, but it has some really great activities for everyone. And if you feel like just zoning out, but getting a bit of education in the meantime, The Principles of Pleasure on Netflix. It's going to give you a whole lot of interesting things to talk about together. There's also a great card game. This has been produced by a Melbourne couple. It's not a sex game, it's an intimacy game. There's a timer, there's cards, they give you little tips, prompts for conversation and prompts for things that you might like to do physically that are really no pressure activities, but it's a lovely way to reconnect. But of course, if you'd like to have a bit more of a deep dive into what's going on in your relationship, Relationships Australia does great couples counselling you can organise through there. And also if you want to think about a bit more about getting some more help, particularly around re-establishing, sexual intimacy with your partner, the Society of Australian Sexologists can point you in a good direction. So wrapping up, 3 things that you can do after today. Please talk with someone about this session. Like, I know that sounds really naff, but actually just getting a bit of confidence, using the word sex in a sentence and feeling okay with that is really powerful. So find someone today, whether that's, you know, maybe it's your friend or your neighbor or your partner. You could just go, oh, you know what? I heard this really interesting thing today. I heard something about sleep and I learned this thing, and then I heard this talk about sex and I thought, yeah. And that's a really great way to start thinking about what might have resonated with you. Maybe write down those questions. If you've got those questions, you think, I want to ask those questions, write them down now. And I'd also, you know, one of the, I guess, a little challenge I'll set for you is find one of those resources that I've mentioned and look it up and have a read. Because the really important message is that your sexual health is such an important part of your overall health, and it's such an important part of quality of life.
Thank you so much, Simone. That was just really interesting. And I'm sure I am not the only health professional watching this video going, wow, I really need to think about the kinds of things that I talk to my patients about. You know, I definitely, when you were putting up those statistics, I definitely thought to myself, I am absolutely guilty of that.
Well, I think it's that thing, isn't it, that we're busy, we're focused on a whole lot of medical things, we're trying to get through things. And like we see from the research, health professionals go, yes, this is important. Like, we all acknowledge it's important. And we have such a role. There's so many suggestions and helpful places we can point people to. But you're right, we're human, and humans are inherently embarrassed about sex. That's okay. Like, I think we'll get there. And I think if we're both trying, if our healthcare professionals are trying and our patients are trying, we're going to meet in the middle. Like, we'll make it work.
So there's patients out there watching, challenge us, you know.
Yes.
Do ask
yes.
questions. Yeah, and we will learn together.
That's it. There's one thing that health professionals are fantastic about. If someone asks a question and they don't know, they're going to bloody go away and find out as much as they can about it. So you're actually helping your health professional learn if you ask them a question. And if they don't have the answer, that's okay. Yeah.
I was writing down those resources. So I have a bit of research going on. Now, look, we do have a question from Deb. So she asks about the impact of steroids and mood swings really impacts the intimacy. What are some tips to manage that?
Yeah, thanks, Deb, for asking about that. I think steroids do lots of things to our body that make sex and intimacy particularly difficult, but I think the mood swings is a huge one. And I would say start really small. And what I mean by that is sometimes if we put a lot of pressure on ourselves to connect intimately with our partner for extended periods of time, like Deb probably realizes, you get pretty frustrated or annoyed, or other feelings come up, or you feel like, oh, but maybe it's about, for example, with that game I mentioned, the game Yum, maybe it's about going, can my partner and I spend 5 minutes 3 times a week? Like, make it almost so small that it feels like, oh, well, of course I can. And then pick a time, start noticing when those mood swings are at their worst and when they're at their best, and going, don't push it. If you feel like you're in a bad mood, it's not the time to try and connect, but harness those moments where you are. Notice where those golden moments where you're like, oh, I actually feel okay right now. Maybe that's the time that I go in for, and I say, can I actually have like a little cuddle for 3 minutes? Can we do that? Or maybe that's the time where we go, let's sit down and both pick out one of these cards and ask each other that question. Because those cards, they have lovely prompts on them to get you. There's so many. I mean, they were made by a couple who spent a lot of time researching this with lots of different people. And it's a nice way. And it also is a bit novel and it's a bit fun. And so it's not you having to think about how you're connecting with your partner. It's like, I pull up a card and the card says, tell your partner about the first time you met and what you thought of them, for example. And so then you think, oh, I know I've got to tell my partner this. And that immediately re-engaging with pleasurable memories from the past is a really powerful way of harnessing good feelings as well. So I would say find something little that feels, and find it that you can put it in at a time when you are feeling good. And when you're having those big mood swings, that's okay. You'll get a bit more resilience in the background to kind of keep that intimacy going.
I think exactly what you were saying before, you know, sex and intimacy is not necessarily intercourse, you know, and thinking about it differently and resetting our mindset about it. And
and one thing I hear from people a lot is that they're really worried about letting their partner down, and they're really worried about not catering to their partner's needs. And especially as the person who's been unwell and sick, there's this feeling of, but my partner's doing all this for me. They've taken on extra chores. They're taking me to appointments. I should at least be able to provide for them sexually. And there's this such a feeling of weight and burden. And I think that's where we really need to step back and have these honest conversations with partners about how we're feeling, what we're worried about, and putting in place small activities that mean that we are coming together in a space that we're connecting outside of the cancer. Because, you know, when there is something like myeloma going on, so much of the conversation and the day-to-day is about what's going on in terms of treatment. But can we carve out these little moments where it's about, I really like you, you know, and how can we have that connection? Because that's the pilot light, you know, that's what keeps that connection in the long term. Yeah, keep the pilot light burning. You gotta, like, you might not be able to fire up that heater or that engine at the moment, and that's fine. That makes a lot of sense as to why you can't.
Spark the light.
But if we keep that pilot light just there, it's going to be a lot easier later on to fire it up again.
Simone, I feel like I could talk with you all afternoon, regardless of what anyone else is thinking right now. We totally could. Talking. I'm learning so much, and I really hope that for everyone out there watching that you've learned a lot from Simone as well, and it's made you think about things a little more, and you know, bring some benefit to you, because you know we are thinking about wellness, not just about our disease and myeloma. We're thinking about, you know, our whole life
and living as full humans, and that's it. Our sexuality is a big part of that. So yeah,
yes, absolutely. Well, thank you so much.
Thank you so much for having me.
Yeah, no, it's a pleasure. I'm sure we'll have you back again.
Love to come back. Bye.
So look, we're going to have a 5-minute break now, and we'll be showing you our latest videos on our campaigns, Joyful Moments, and our CAR T cell therapy campaign. But please feel free to use the next 5 minutes to stretch your legs, dash to the toilet, or grab a cuppa and come back and join us for the last hour of our final seminar for this year. Thanks so much.
Hi everyone. Last year we introduced you to 38Mate, an awareness campaign that shone a light on myeloma and the 38 Australians diagnosed each week. This year, I want to tell you about our new campaign, Joyful Moments. This campaign celebrates all the wonderful things our 38 mates, their carers, and our community enjoy. Maybe it's a new hobby you've taken up or an old passion that you've found a new way to enjoy. We'd love for you to share your joy with our community. Maybe you love fishing, swimming, bushwalking, playing music, or something completely different. I've been with Myeloma Australia for a number of years now, and over that time I've met so many wonderful Australians who love doing so many different things. We know that being diagnosed with myeloma can have a significant impact on your life, making it difficult to do things you used to do. But sometimes it's possible to do the things you enjoy, just in a slightly different way. So while we spend a lot of time talking with you about myeloma and all that goes with adapting your life to living with it, we want to take some time out to celebrate all the amazing things that you do when you are being you. Because that's really the goal of everything we do, to support you to spend more time being you. Joyful Moments also fits perfectly with our focus for Myeloma Awareness Month. In May, we will have seminars focused on wellbeing and possibility, reflecting the hope that new treatment advances are bringing in myeloma. We know that at the heart of wellbeing is doing more of what you enjoy and what makes you feel happy. Sharing what makes you feel good may also inspire others to take up a similar interest and spread the joy further. So over the next few weeks, we want to hear from you, your family and friends. Just complete the sentence, I'm a 38 mate and I love, or I care for a 38 mate and I love. And send a photo or video of you doing whatever it is you love to do. Simply email 38mate@myeloma.org.au. We'll then post your pictures and videos sharing joyful moments across the myeloma and wider community. We really look forward to seeing your photos and videos. Thank you.
Hello everyone and welcome back from our break. My name is Tina and I'm a myeloma support nurse from New South Wales. Just a reminder for people to use the chat function to send in any questions for our speakers today. Next, I would like to introduce our third speaker for today, Maria McDonald. Maria has had 40 years experience as a registered nurse. 15 of those years more recently were in haematology, where she found her true passion. During this time working in haematology, she completed her Nursing in Cancer certificate through the College of Nursing. This course had an elective component to it, and Maria's choice was to focus on myeloma. In the last 5 years, Maria has moved her career focus from nursing to pastoral care. She completed the education needed to gain employment in this field and now works as a pastoral care practitioner at Calvary Mater, Newcastle, which is predominantly a cancer hospital, including a haematology unit. She has a grown-up family of 3 boys, all in their 20s, and is currently enjoying her empty nest with her husband. Today, Maria will be talking about caring for the carer. Thank you, Maria.
Okay. Good afternoon, everyone, to everyone who's tuned in today, and thank you to Tina for your introduction. Thank you also to Rachel and Juliet and Myeloma Australia for giving me this opportunity to speak today. The topic I've been asked to speak on is self-care, and specifically to be mindful or focused on the self-care needs of those who are carers, those who care for people with myeloma. So before I start, I'd like to say it's important that if anything that we talk about today brings up issues for you or makes you feel uncomfortable, please contact Myeloma Australia. There are people there on the end of the phone that are waiting and ready to help. So when we look at the work that carers do, we find that there are varying types of roles and varying levels of demands on carers. This can be anything from helping out for an hour up to being a full-time carer. It can be a paid position or an unpaid position. It could be a family member. In particular, it could be a spouse or a partner. The information today hopefully will touch on most caring roles in some way, but there is a focus on what we call a primary carer. A primary carer is the one who is dependent upon most when multiple carers are involved. So it's the first go-to person, other than the person with myeloma, who is helping support. It's the organiser. If the person with myeloma is struggling to organise themselves, it's the person who does the majority of the organising. So I'd just like to look at when someone's given a diagnosis of myeloma, there is often an emotional response, not just by the person with the diagnosis, but also for those around them. The response may be possibly one of shock, one of feeling of uncertainty about the future. And the path the person that has the diagnosis on prior to the diagnosis changes. And change like this one will always bring about an array of feelings. Then as you, the person you are caring for, walk this new path together with the support of the medical teams and hopefully those around you, you may find it to be a bit of an emotional roller coaster. And not just up and down, it can be slow at times and be really fast at times. So myeloma is largely an ongoing, or to use the correct medical term, a chronic disease that fluctuates. So in the beginning, there may be, of the diagnosis, there may be a very big help response around you. But that may fade over time, and it just leaves you, the carer, and the person you're caring for, to live through things like the tension felt every time there's a blood test, or the waiting to see if this round of treatment is going to have the desired effect. As a primary carer for someone with myeloma, you will possibly go through similar, if not the same feelings and thoughts as those with the disease. In fact, your focus on them means you live their ups and downs as well as your own ups and downs. So I want to first of all acknowledge some of the feelings and those experiences that those who are carers may have when they find themselves in a caring role. And very often it's a role that's not of choice. Now, I'd like to note that what we're going to look at next, some may feel some of these, one of them, two of them. There'll be a variety in looking at what we feel when we're in this type of situation. So, but please be sure that later in the talk, I'll have some strategies for self-care to help with a lot of this. So let's have a look at what you may be experiencing or feeling. So the first one up there on the list is grief and loss and some sadness. So transitioning to a new normal, a new way of being, one you didn't ask for. Your vision of the future changed and all out of your control. This is loss. What if the person I'm caring for dies? You don't have to have someone die to feel grief. The thought of it can bring on that feeling. You may feel angry and frustrated. Why us? Why me? Frustrations with navigating the healthcare system, and that can be really, really frustrating. Your stress levels and your anxiety levels may be heightened. You know, as a patient or a carer, it could mean changes in employment, reducing time at work and therefore income, and all the worries that come with that decreased income. If your identity is largely through your work and now you're only working part-time or you can't work at all, who am I? You know, if I'm not a teacher, who am I? If I'm not a lawyer, who am I? If I'm not the breadwinner, who am I? The other, you may feel guilt. Guilt over being at times angry that this is happening. Guilt that you're struggling to meet the needs as a carer. You know, all those needs that are being demanded of you and you're just struggling to meet all of, and then you feel guilty if you can't meet them. Am I feeling burdened? And now I feel guilty about feeling burdened. The next one down is you may feel alone or isolated or helpless. The focus, quite understandably, is on the person with the myeloma. But what happens if things don't go to plan? As a carer, you have no control over this. How do I manage these feelings of helplessness? I'd just like to share a statistic with you that I was surprised at when I was doing some research on this. And across the board, across Australia, the whole population, and this is not just myeloma, 1 in 8 Australians are carers in some way. So that's a large part of the population. So maybe sometimes when you're feeling alone, just remind yourself that there are people out there who are living through similar circumstances to what you are. You may feel trapped and overwhelmed when it's just all too much and I can't find my feet. I've lost my anchor. I can't put thoughts together. I'm so overwhelmed, I just can't think logically. Your faith may be challenged. If you have a strong faith, it may be challenged by this, you know. I and we have been good people and followed the teachings of my faith. Why would God do this to me and to us? You may find that there's physical changes go on. You may have changes in appetite, might have difficulty sleeping. You might be tired all the time. Some carers, they may have some positive things, positive feelings around caring for someone. You know, it suddenly gives them a very strong sense of purpose, or they get a very strong sense of connection. So some people do have positive come out of becoming carers. So you may have felt all of these, or some at some stage, or maybe a few, or none of them. The important thing is to recognise these as feelings and to know that you are normal. So we know that we are normal, which is the top sentence there, or comment up the top there. So with the fluctuations that can come with myeloma and hopefully the years to be lived with the disease, there's a need for resilience as a carer. To have resilience, you must ensure good self-care is a normal part of your world. Self-care is not something that comes naturally to a lot of us. It needs attention and it needs to be built up as a habit. So the important bit is to know that you are normal, that to continue on as a carer, you're probably going to need some resilience, and that there's help out there with self-care. So what does self-care look like? Now, the Australian Centre for Grief and Bereavement, this is their definition of self-care. So self-care is a very active and powerful choice to engage in activities that maintain an optimal level of overall health. This includes not just physical, but also psychological, emotional, social, and spiritual components of an individual's well-being. Another statistic that I found out while I was doing research is that, and this is across the board, not just myeloma, carers are 40% more likely to suffer from chronic health issues than the rest of the population. And that's a very big percentage of carers to be living with chronic health issues. So we have the grief and bereavement definition. The World Health Organization also has a definition for it, which just gives weight to how important self-care is. It's a little more academic and technical, but put more simply for us in our daily existence, taking care of yourself is the most powerful way to begin to take care of others. We need to remember that when we are carers, that this is a marathon and it's not a sprint. So we could sit back and think about self-care, and we could make a practical list of common activities that would normally be seen as self-care activities, like going for a walk, spending some time reading, gardening, patting the dog. The list is endless because self-care activities have no limit. The key is knowing what works for you. The key is awareness of ourselves. Oh, I just lost my clicker. Yeah. So sorry about that. To self-care, we need to have awareness of ourselves. We need to know what nourishes me, what recharges my batteries, what drains me, what gets me out of bed in the morning. When am I less effective? Where in my body do I feel stress? You know, if I'm feeling stressed or overwhelmed, do I get nauseated? Or do I just feel like I'm heavy chested? Where do I feel that in my body? How do I know I'm stressed? So just thinking about ourselves and these types of questions can increase our awareness about ourselves. And the last one there that says, how do I know I'm stressed? I'd just like to take a couple of moments just to talk about stress in general. Stress has two sides to it. It has a positive side and a negative side. We need some stress in our lives to develop our coping skills, but too much or prolonged stress can have a detrimental effects on our well-being. And it's getting the balance that matters, because we can't get away from it. It is going to be there. So it's about how do we get that balance. So this is where the good news comes in about our feelings and our responses and our stress levels. We can influence them to have some balance through really good self-care. And so in the next 3 slides, I'm going to give you some strategies on how to do that, because I'd much rather empower you with some strategies than sit with a list of things a mile long that you can just try out. First of all, recognise and increase your awareness of your reactions, which is what we were talking about just before with the questions that I had up there. Recognise what you can and can't change or control. If you can, learn how to let go of what you can't control. Now, I understand this is easier said than done, but if you can do it, you will find that you feel much less burdened. Have realistic expectations of yourself. Your world has changed and it continues to change. Living with myeloma is part of it. So include those changes and the possibility of the limitations that you now have when thinking of realistic expectations of what you can put in place for your self-care. So one of the thoughts might be, how much time can I make available for self-care? Can I allocate a whole day, or can I just do 30 minutes in the morning each morning? Or can I, for 3 mornings a week, allocate 2 hours to go out and do something for myself? Be realistic about what is possible in your own individual circumstances. Take time, do something fun, simply be. We live in a high expectation, fast moving world. Give yourself permission to just be. As human beings, if we can learn to just be, it does really nourish us. Talk to people. I've learnt this. There's a thing called the rule of 5s, and it makes me think of 5 fingers, but have 5 people that you know of on hand that you can talk to at any time. Now that may be talk with friends, talk with family, counsellors, as we have up there, but I would recommend that you put into that one of 5, having contact with Myeloma Australia. My understanding is there's always someone there who is willing to answer your questions and be supportive. So in those 5 that you think of to have on hand, just include Myeloma Australia. Eat healthy food, get adequate sleep and exercise. Now, if you're like me with this one, it requires a little bit of discipline. This is not one of my strong areas. So maybe with things like, for example, exercise, put something in place that can keep you accountable. Organise to walk with a friend once a week and ask them to make you accountable, to make sure you turn up on that day. Just little strategies like that can keep your eating and sleep and exercise in a good daily and weekly pattern. Be kind to yourself. If something doesn't work, try not to judge yourself. Self-talk to yourself like you would talk to a friend who was in your position. Self-talk, talk to yourself kindly. It's very important. Include humour wherever possible. Now, this is my favourite one. It's one of my big strategies personally, as well as talking to friends and having a laugh with friends. I make sure at least 3 times a year I get to some sort of comedy festival. So at the beginning of the year, I'm guaranteed I'm going to have at least 3 nights a year where I just laugh my head off. So humour is very, very antidotal to feeling down or feeling lousy. So I encourage you to look at how you can pull more humour into your life. Unless you're a funny person and there's a lot there, then that's great. Celebrate when good self-care works. Remember to pat yourself on the back. My understanding is that the Myeloma Australia website has a thing called joyful moments that you can post things on. I suggest that if you find something that works really well for you in self-care, post it on the joyful moments part of the website and share it with everyone. I'm sure they would love to hear from you. Our last one here is learn to slow your breathing, relax your body and your mind. There's quite a bit of research around this now that shows that if you can control your breathing or do some meditation, that it can be very helpful. It does not have to be complicated. It can be as simple as breathe in for the count of 4, hold it for the count of 4, and breathe out for the count of 4. And if you do this, just do it 10 times once a day, it can effectively slow and deepen and relax your regular breathing. So that's the 9, at least 9 suggestions that I have along strategies. what I'd like to say is that nobody knows you better than you. I would invite you to spend some time reflecting and thinking about what works for you, what has worked in the past, and what have I always felt would work but haven't tried yet. Be flexible in trying things out to see if they work. If self-care is something that you've never been focused on before, then there's going to be a little bit of a learning curve. Try to see it as an adventure. What I do know is if you can find what works for you, not just you will benefit, but those around you will also feel the benefit. And my last slide has Post-it notes all over it because I'm a Post-it note girl and I live by Post-it notes. And if I didn't have them, I wouldn't know where I was or what I was doing. So I wanted to give you what I would call a bit of fun homework simply because it involves Post-it notes. And I would say within the next day or so, after having listened to this talk, I encourage you to sit in your comfy chair, go and sit under your favourite tree, or after some meditation, spend some time reflecting on what nourishes you, what makes you feel like you, and see if you can come up with 3 really realistic ideas for personal self-care. Write them on a Post-it note and stick it on the fridge. Look at it daily and explore the implementation of these ideas. Are they doable? And if so, go ahead and just jump in. My time is up for talking, and I'm not sure whether we have enough time for questions, but Tina will let us know if anyone has one. But before the questions, I'd like to reiterate what I said at the beginning, and that is, if any of this presentation has brought up issues for you or made you feel uncomfortable, please contact Myeloma Australia. They are there to help. Thank you.
Thank you so much, Maria. What an informative talk today. Some great self-care tips there for everybody. And thanks very much for suggesting that people use our Joyful Moments campaign. What a wonderful idea. I do have a few questions here for you. We might just do the first one, just running out of time a little bit.
That's
First
okay.
question's from Tom. I can't meditate and deep breathing does nothing for me. Do you have any tips around this?
I do. People think they can't meditate or that it doesn't work because it's meditation and deep breathing exercises. Sometimes they can relieve in the moment, but they're actually a long-term strategy. You need to, it's almost like make it do it till you, fake it till you make it. What happens is that you think it's doing nothing, and then if you actually manage to do it for, say, 4 months, for example, or 6 months, it's not that you notice the daily difference. It's when you look back and you realise, gee, I am a little bit calmer than what I used to be. So it's not necessarily a quick fix strategy. The Buddhists would tell you this is not a quick fix if you're talking about meditation. We do know that deep breathing affects the autonomic nervous system in the human body, and this is the area of the brain that controls part of the brain that can control or influences emotional processing, hormone regulation, and perception and thoughts. So there's a science behind it in that it can work. I would just encourage you to persist with it. I know it's hard work when you don't get any immediate feedback, but it is a very good long-term strategy.
Okay, thank you, Maria.
Does that make sense?
Does make sense. Thank you.
Yeah.
That wraps up our session today with Maria. Thank you again for generously giving your time. We really appreciate it, Maria.
You're welcome. Thank you.
Next, I would like to introduce the wonderful Narelle Smith, who's a myeloma support nurse in Western Australia. She has worked with Myeloma Australia since 2017. She'll be conducting a patient and carer interview with Peter and Deirdre Brune. Over to you, Narelle.
Thank you so much, Tina, and hello, everyone. My name is Narelle Smith, as Tina just mentioned, and yes, I am the myeloma support nurse for WA. And today I'm joined by a couple who I have had the privilege of knowing for many years, Peter and Deirdre Brune. Peter has been living with myeloma for the past 6.5 years, and Deirdre is Peter's wife and support person. I've been lucky enough to know them for most of the time that Pete has had myeloma. Thank you both so much for joining me today to share with everyone a little bit about your experiences in living with myeloma.
So that's over to us now, Narelle.
How are you?
Thanks, Narelle, and thanks also. Good morning, because we're in Western Australia. So good morning to all the people listening today on the seminar, and thank you very much indeed, Narelle and Myeloma Australia, for giving us the opportunity. So over to you. What sort of questions have you got for us today?
Well, Pete, I was going to ask you first if you could just tell us and everyone watching a little bit about how you were diagnosed with myeloma and what treatments you've had to date and where you're at now.
Oh, that's for 6.5 years. I'll condense it all down for you. My first recollection probably was about 2 years before being diagnosed, where I had severe bone pain, and most of us do get a bit of bone pain from time to time, certainly in my ribs and in my back. Over a 9-month period, I visited doctors on 8 occasions. I was told hernia, diverticulitis, pulled muscles. It was only when Deirdre suggested that I go to see her doctor that we did a specific blood test, and I was diagnosed at that time with myeloma. I then had a bone marrow biopsy. Then on the next day, and then I started my induction, VCD, Velcade, cyclophosphamide and dexamethasone. Some of those of you will be familiar with that. Had a 3 months induction. Then I had my stem cell transplant in February 2016, February the 11th, my new stem cell birthday. And I had a very good partial response. And I think some people have the notion that a stem cell transplant is the panacea and that they'll be cured. Well, I had a very good partial response, which meant that my myeloma was still in my blood. I then didn't have anything happening then for a while. I was on a little bit of maintenance. And in 2017, myeloma came back. So I had a relapse, and myeloma is a refractory cancer, which means it does come back. I was first put on thalidomide. I hope I'm not speaking too quickly. Put on thalidomide, did my head in. I had peripheral neuropathy, brain fog. So then I went on Revlimid or lenalidomide. I've been on that since middle of 2017, and I've been very fortunate because it's agreed with me, and not all the meds agree with all of us, but I've been in serological remission since 2018, and I've been very fortunate in the sense that I stay on lenalidomide and dexamethasone, plus the other lot of rat sack that we get from time to time. So hopefully that's answered your question. I've been very lucky. I know all the meds don't agree with everyone, and it's just finding the balance with myeloma and talking to your clinicians and asking all the right questions and finding out what those side effects of those medications do have on our body.
So you've mentioned quite a lengthy process of what you've been through over the past 6.5 years, and you do have a pretty positive outlook on everything, and I know that to be true. But what have been some of the challenges or the things that you've found difficult, but also any other positives that you haven't already mentioned?
That's another interesting question. I think one of the main challenges I've had is the frustration of not knowing that your life has changed significantly, not being able to do the things that you could do before. Sometimes the mind is willing, but the body is weak. And I know some mornings when you wake up and you feel a bit fatigued, or during the day you feel fatigued. And I'm sure that a lot of the myeloma, I say sufferers, but really it's warriors, that they wake up in the morning, you don't feel as chipper as you used to when you're a young buck, you know, and you wake up and you think, oh, I'd like to do that today, but really I don't feel so crash hot. So it's the frustration of that, the fatigue. I have a little bit of time where I have a bit of lack of memory, and that's, I think I put it down to age, but also the medication. I get bone pain from time to time, brain fog. My balance isn't as good as it used to be. And the stress, I think Maria in the last session talked about the stress. it's the stress and anxiety of not knowing what's ahead, sometimes from time to time. So that's the sort of challenges. And the other thing is knowing, the biggest problem is also knowing the side effects from the medication that we take. Some of them have different effects on our body. And as we get older, and some I'm fortunate, and other people aren't as fortunate health-wise as myself, and some of those meds can, a bit hard to cope with. I'm very positive. I said to you, and I've known you for a long time, Narelle, that I think 90% of everything is between the ears. I think you've got to take this as a journey. It's just someone's dealt you a bad card, and you just got to get on with life and, have the wind in your face and the sun on your back, and just get on with life and not sit in the fetal position and get on with things. Enjoy life and what the challenges put in front of you.
You're absolutely right. And the other thing I think that came out of Maria's presentation just then was the importance of humour, and that's something that you're never short of, which is always welcome.
No.
and Dee, I'd love to hear from you now. So I'd love to know how Pete's diagnosis impacted your lives, and how has your experience of being a wife and carer changed over the course of Pete living with myeloma?
Sure. Well, obviously the diagnosis was totally life-changing. We ran together a very successful real estate business. And when Pete was diagnosed, we had to virtually thrust our eldest daughter, Chelsea, into the chair, who had no experience, by the way, to start running our real estate business. So she did that while Pete was having his stem cell transplant. So obviously our life was in turmoil. We didn't know what to expect or what lay ahead. We ended up selling our real estate business a few years down the track, and we moved to the country where we are now, Dunsborough. And that was because of Pete's astute business knowledge, and he had some insurances in place which afforded us the financial opportunity to come to this beautiful part of the world. And we made the change because of the serene lifestyle. We needed to get away from the stress of the business and sort of what Perth held for us. So it was the best move for both of us. And did you ask the second part of the question, though? So as a carer, it was extremely hard when Pete was diagnosed, because obviously we didn't know what to expect. Pete's always been a very strong, robust, physical man, and that changed completely. So I've had to sort of rethink what I ask Pete to do, daily tasks. He can't, as he mentioned, the balance issue is some days good, some days not so good. Moving furniture, Pete, can you give me a hand to move this? I don't rely on him to do that anymore. As the cancer has progressed, his brain sharpness and astuteness has definitely decreased. So I have to be very, very specific. Sometimes we have some funny things at cross purposes. I have to be very specific with answers I give him or instructions or whatever. But he's just not real sharp on the pickup sometimes, I think as he used to be.
That's called domestic deafness, and all husbands have that.
So I think also, just as a carer, Pete's always had a role in life, and that was being the breadwinner and providing for us. And I think he's struggling with that a little bit more. So hopefully quite soon he needs to find his niche again in life down here, whilst juggling myeloma, of course.
Yes. So you mentioned just in your answer just now about how you're now living down in Dunsborough, and you've actually lived part of the time that Pete has been living with myeloma in the Perth metropolitan area, which is where I first met you, and then you moved down to Dunsborough. Could you both just talk a bit about how those two really different environments and experiences have affected your lives of living with myeloma and getting treatment and everything that comes with it?
Who wants to go first? Well, I think that one of the problems is living in regional Australia is the lack of medical services. And, we have our regional hospitals 30 k's away. And then we've got a smaller hospital than in Perth, in Bunbury, it's an hour and a half away. There's no haematologist down here in the southwest, and there's very few access to specialists. And of course, in Perth, where I met you at Hollywood Hospital, Narelle, some 6.5 years ago, there's a plethora of specialists around there. You can just pick up the phone, you can get admitted to hospital, and a specialist is going to be there. Lack of ambulance services. Paxlovid, one of the viral drugs for COVID now, there's a 10-day waiting list. We've run out down here in the southwest. So I don't know where each other chemists have it, and it's those sorts of things. It's the challenges. If I have to go to Perth for anything, it's a 3-hour drive there, 3-hour drive back. So it's those sorts of things living regionally. The positives, though, of course, is that you have a much easier life, the traffic and all of those parking and all of those sorts of things. Those things diminish when you come and live in regional Western Australia. But living with myeloma, you suddenly find that there is a lot of other people around you in the country that have myeloma. And we have a very good, strong support group down here, which I attend regularly. And yeah, we've got a good bunch of people down here. You'd be surprised how many in the southwest actually have myeloma. And we band together and are all friends working for the same common goal. I think my 4-letter word in myeloma is hope. That's the one I say all the time, that we're going to have hope to get a cure. Over to you, Dex,
I think if we were living in Perth, I think we'd be a little bit more understanding of Pete's symptoms sometimes. But being in the country, anytime there's a little spike in his temperature, for instance, and he's feeling slightly unwell, Pete's got his bag packed and we're sort of ready to make that 30-minute dash to Busselton Hospital. So I think we're a little bit more on guard, if you like. We purchased this thermometer, who actually a registered nurse said you must get one. So that actually gives us a level of comfort. And this oxygen reading, oximeter. So we have that. We have those 2 new gizmos, which the minute Pete feels a bit unwell, he's on them. So that gives me a bit of comfort also that, do we need to go to hospital, don't we? Because it's not just around the corner here. So from my point of view, that's sort of given us a little bit more of a comfort in a sometimes, stressful situation.
Thank you for giving the audience a bit of insight into the real differences and how it can be really challenging living regionally, and the changes that you've had to make yourselves to be more vigilant, more aware, and self-reliant. So thank you for that. Now another question for both of you, and Pete, you can answer this first. It's about self-care, which I hope will become your next favourite word apart from hope. He was mentioning you were going to be spending more time doing things for yourself. So we know self-care gets talked about a lot, and it's really important for our physical as well as our mental health. So what do you do together or separately to look after yourselves? Pete, you go first. Thank you.
Well, I was up in Perth only on last Monday, and I've been given the go-ahead to now start back and doing Pilates again, which I do enjoy, just not, going bull at the gate like I would have done when I was a bit younger, but, walking, those sorts of things as well. I know that with some of the steroidal medications, they do make you hungry, so I have to try and discipline myself. But as you know, I've said to you before, if they didn't want you to eat at night, they wouldn't put a light in the fridge. So unfortunately on dexamethasone, and those sorts of steroids, they do make you a little bit hungry. So I've got to discipline myself there. Self-care, we walk as often as we can. I try and do a little bit of work around. We're on rural property, so I try and, you know, do a little bit of workout. So there's always something to do here. But sometimes also, when you wake up in the morning, you don't sometimes feel like doing anything. You feel a bit stiff and sore, and you might not have had a good night's sleep. You've got to get your head space right to say, like, I'm going to start to do this, and motivate yourself to get and do just something. It might even just be making the bed, but just doing something for yourself and celebrate those little victories. Maybe one day I'll do that.
Do you do that? Yeah.
Maybe one day I'll start that.
I hadn't noticed.
I've got to start it one day. But yes, that's it. You know, we try and do as much. We're in a beautiful part of the world down here in the wine area of the southwest region of Western Australia. So, you know, we're very fortunate in that regard. Dee, what do we do together?
We walk together, but I'm an avid Pilates attendee, and that gives me a lot of self-care. I wish I'd actually started 10 years ago. I love it. And I paint. So I have my therapy room, I call it, and I lose myself there on most days. So that means I can get lost and paint and cut and tear and all sorts of things whilst playing music. So that really is self-care for me.
Leading on from that, actually, Dee, what advice would you give to other people who are caring for a loved one with myeloma?
Well, firstly, as we've mentioned, you've got to stay positive and you have to have a sense of humour. So married to Pete, that's very easy, as you know. But I think also you should attend all doctor's visits and medical visits and be fully across all medications and sorry, it's the cat.
We were hoping it wouldn't happen.
Fully across all medications and effects, and obviously understanding the good days and the bad days of the cycle, and adjust yourself. For instance, if it's a Dexy day, just know you can't discuss anything that's slightly personal or controversial, because there's a Jekyll and Hyde situation going on. So understanding the cycles is very important. Pete has a zest for knowledge, anything myeloma related. The trials, the new medications, he gets newsletters and printouts from all over the world. So he's fully across whatever's happening in myeloma. So that helps me as a carer. He's always telling me about new meds, all positive. So that gives us huge hope for treatment in the future. And that helps me with my positiveness too, that it's not all doom and gloom.
And Narelle, just to never do seminars with children or pets. We said before, that we hope the cat doesn't play up, but you just, you know, typical of a cat.
We like to keep it real. We like to keep it real. And actually, we're up to our last question, which is just one final one for you, Pete. So what are some of the things that you wished you knew when you were first diagnosed, maybe through your transplant or afterwards through your maintenance and now while you're on your lenalidomide, that you might want to share with everyone?
And that's a hard question, you know. That's a good question. I think because I was so busy in our own business and always striving, you know, to working hard to try and provide for the family, and you're focused and everything else, is that how important is to take stock of your life and work out what's important. You know, I missed a lot of parent days. I missed a lot of the athletics days and all of that sort of stuff, working, you know, full time all the time. And I think myeloma makes you realise that you've got to take stock of your life and sometimes take some me time to smell the roses and spend that time with both family and friends. You know, my mum's 90, but, you know, wish I could spend more time. She's in Perth, 3 hours away. But, you know, with grandparents, with friends. Maria said in the last session, you know, about spending time with 5 people, knowing, you know, just having a cup of tea and just talking secret men's business with a bloke about the footy or the cricket or something, but just taking a step back from that stressful life. And I think that's what myeloma does to do it. It forces you to do that. And I wish I'd known about, you know, how wonderful it is sometimes to take a little bit of a stress break. Takes, as I said, some me time to smell the roses. And also I get a lot of pleasure now out of helping other myeloma people that are not, as I said, health-wise, not as fortunate as me, and helping them through maybe the stem cell journey as well, because we all don't know what to expect, and myeloma treats us all differently. You know, it's an individual disease. It's not a broad brush vanilla version cancer. It just, and there's different subtypes, and, you know, there's light chain and heavy chain. There's all of these little nuances that come into it that people, you know, you can't sort of get a broad brush and say, that's what's going to happen. So also, I wish I'd known more about things, and I do enjoy that Deirdre comes along to the sessions with me, because you do forget things. But talk to your clinicians, talk to your myeloma nurses, go on the Facebook page. There's 2,500 people now on our Facebook page where we share our experiences, where clinicians can't talk about certain things. You know, we talk about things like bowels and wheeze and things like this, which you can't talk about. You can do with a clinician, but we all suffer the same sort of fate. And so, you know, there's 2,500 there. Talk to your clinician, talk to Myeloma Australia, and give support to your fellow myeloma sufferers or warriors.
And I can certainly attest that you have been a great support to people in the myeloma community, and that has been from the very beginning since I first met you, and it's ongoing, and it's always a pleasure to have you along to the groups and to have you sharing your experiences and your insight. And I want to probably stop it there, because I know we could talk all day and we have many times before. But I really, it's always such a treat to talk to you both. And I think the people who are watching will also agree that it's been a treat to listen to you both and get your insight on your experiences. And I just want to say thank you so much from the bottom of my heart for coming along today.
Oh,
Thanks,
you.
Narelle. I think the last thing I could say is that Muhammad Ali said, don't count every day, make every day count. And that's so important with myeloma. It's not the end of the road, it's just a speed bump. And so when you hit that speed bump, it just forces you to slow down a little bit. But life just goes on, and you've got to get on with life.
I couldn't agree more.
Thank you, and thank you to Myeloma Australia
to
allowing us to have a chat today. Thank you.
Thank you. Thank you. And I'm now going to hand back over to Tina and then Nella for rounding up the seminar series and some closing remarks. Thank you.
Thank you.
Thank you.
Thank you. Thank you, Narelle, Peter and Deirdre. What a great insight you've given us all today. What a wonderful topic to finish off with. That concludes our presentations for today. Thank you to all involved for sharing your knowledge with us. I will now hand over to Nella Coombe, who's a nurse manager at Myeloma Australia, and she'll conclude today's seminar. Thank you, Nella.
Thanks so much, Tina. And thank you, Dee and Peter, for sharing your story with us. On behalf of the Myeloma Australia team, it's my pleasure to wrap up this year's National Myeloma Month online seminars. We hope that you have had the opportunity to listen in to all three of them, or even just part of them. We've had some great speakers around our theme this year of wellbeing and possibility. And we thank them all very, very much for giving up their time, sharing their knowledge and expertise and experiences too, so that we can learn a little bit more. Thank you also to our Myeloma Australia team who have been involved in this year's program. Our nurses, some of them you've seen chairing sessions. Others have been busy working in the background, and everyone's been involved. Also, we have a great admin and support services team here, which we couldn't do any of this without. So thank you to everybody. One last thank you to the CVP crew who make all of this happen and make it so easy for us to be able to deal with all of the IT side of these online webinars. We really appreciate all of your support and working with you, as well as our two other supporters, Janssen and Roche. The recordings of all three seminars will be available on our web page, our website, for quite some time. So you can go back and watch any of them anytime you like. The first two are already there, and this last one will be up in within a week. So please do take some time to go back and watch anything that you missed, and you can do that anytime you like. We also, just before we finish off, I'd like to give you a quick reminder that the consumer comments for the CAR T-cell product Cilta-cel in myeloma that is being considered by the MSAC body will be closing on June 10. If you would like some more information about this, you can go to our webpage, our website, where we have a button on the front page where you can click and find out more, or you can even just give our telephone support line a call and one of our nurses will be able to help you there. Also like to encourage you to get involved in our Joyful Moments campaign. It's been a great session today to lead into that, and it's already been mentioned a few times. We'd love to see your pictures. We've got a little gallery already being populated on our website, so please do send in any photos you have of you doing something that you love doing. It doesn't have to be, it doesn't have to be super impressive, because we already think that you're doing a great job and we just want to share it with everybody. So nothing is too small to share. Anything that you'd like to send through, just do so to 38mate@myeloma.org.au. Finally, thank you so much for joining us today. We hope that you had enjoyed the seminar and that the rest of your day is a good one, as well as the rest of your month, National Myeloma Month. Thank you.